Hello and welcome to our talks today. We're going to be talking about improving care across the spectrum of Huntington's disease, from diagnosis to management of symptoms. I'm joined today by my friend and colleague, Mr. Kevin Williams. I'm Victor Sung. I'm a professor of neurology at UAB. These are our disclosures. This program is provided by HMP Education, an HMP global company, and is supported by an independent educational grant from Neurocrine Biosciences. These are our learning objectives for this initial talk today. So starting into the timing and impact of motor, cognitive, psychiatric manifestations of HD. This will be the focus of this first talk, and I will kick us off. So as a means of background introduction to Huntington's disease, it was first described by George Huntington in 1872, and he noticed that familial aspect of it, that it was transmitted from one generation to the next. And you know, remember, this is before the Human Genome Project, before we really had this strong understanding of genetic diseases, but he already noticed that pattern. And Huntington's disease is your prototypical pure genetic disorder. It's autosomal dominant in its inheritance pattern, and it's neurodegenerative so that it progresses once it begins. It's adult onset. As far as its incidence and prevalence across the world, there's some variation in different regions of the country. The last global prevalence statement was in 2012 with a global prevalence of about 2.71 per 100,000. In Western populations in kind of the United States, it's thought to be about much higher than that, in more of the prevalence in the 10 to 13 per 100,000 range. And there are some slight differences in the genetics of the disease based on populations of different ethnic descent. So that's listed there at the bottom. And we're going to talk more about the genetics of the disease as well. As a brief means of history, there's a lot of history that goes into understanding the disease, and a lot of the genetics came from the country of Venezuela. In this region of Maracaibo, has the highest concentration of HD in the world. It's geographically isolated in this mountainous village on the edge of a lake, and the original progenitor lived in the early 1800s and has now left greater than 18,000 affected descendants in the area with Huntington's disease. The prevalence of HD in that region, much higher, thought to be 40 to 50% of the population there that's affected. So obviously this is a great place to study HD, and Nancy Wexler, who has a family history of HD herself, and in the article cited at the bottom, talks about that she has tested positive for HD herself now. But at the time, in the late 70s, early 80s, she did not know that. We did not have the gene sequenced, and she pioneered this effort that led to the discovery of the HD gene. Fascinating work. I encourage you to read about it sometime. And that work led to the sequencing of the gene in 1993 after a 10-year effort. The Huntington's disease gene is located in exon 1 on the short arm of chromosome 4 and consists of a trinucleotide CAG repeat. This was really the first trinucleotide repeat disorder sequenced and described. And for Huntington's disease, it is autosomal dominant with a 100% penetrance, which means you really don't get any asymptomatic carriers. You can have rare homozygotes, but it would require two persons with Huntington's disease to have an offspring together, and then that person could potentially be a homozygote. But the other side of it, because of this clear genetic inheritance and this gene mutation causes the disease, it gives us a clear target for curative or disease-modifying treatments. As far as HD pathogenesis, there's selective atrophy of the medium spiny neurons in the striatum, which is the caudate and putamen. And the medium spiny neurons comprise greater than 90% of the neurons in that area of the brain. And it disrupts the output from the basal ganglia. And when it does so, it affects all areas, motor, cognitive, and behavioral control. There is accumulation of this insoluble mutant Huntington protein, and that accumulation leads to widespread neurodegeneration, starting in the basal ganglia, but also spreading throughout the rest of the brain over time. And as far as what does this mutant Huntington protein do, there are both toxic gain of function and loss of function mechanisms that lead to the neurodegeneration in HD. The average age of symptom onset is in your 30s to 50s. The graph here on the right shows you the correlation between your CAG repeat expansion number and age of motor symptom onset, which is kind of how this is graphed here. If you think about that, one of the significant impacts is going to be that if you take out your 30s to 50s when you're starting to become symptomatic, those are your primary wage earning years. And so therefore, this disease has this significant socioeconomic impact for the patient and their family. And then you combine in that with an autosomal dominant inheritance pattern, there may be multiple family members affected across multiple generations, then it tends to have this downward socioeconomic pressure on a family over many generations, which is a significant challenge. The diagnosis of the disease, since we have this gene test now, since the gene was sequenced in 1993, is really based on clinical evaluation combined with confirmatory genetic testing. So what is the clinical presentation? How do we make that clinical recognition of HD? The three areas of the disease that are affected are the motor, the cognitive, and the psychiatric, which we call the HD triad. And with that, we'll talk with our patient and care partner and hear about their experience with the diagnosis and the symptoms and how it's impacted their life and their family. Good afternoon, everyone. I'm Dr. Victor Sung. I'm a neurologist, HD specialist, and I'm privileged to be joined here this afternoon by one of my patients and his wife and caregiver. If Mr. and Mrs. Duggar, if y'all could introduce yourselves.
My name is Tom Duggar.
And my name is Sheila Duggar.
We live in Muscle Shoals, Alabama.
All right, thank you for joining us today.
Thank you.
I just wanted to start with, tell me a little bit about the story of your coming to an HD diagnosis. So kind of what symptoms were you experiencing? How did it lead you coming to my office? And what were your thoughts heading into that first visit?
Well, the reason I came into your office was I was having some movements with my fingers. And I thought that I was just drinking too much coffee. And I was taking some medications for nerves or whatever. And I thought it might have been part of that.
Okay. He had actually had a tendon tear repair surgery done sometime before we actually met you. And his doctor had put him on some gabapentin. And he never had any kind of involuntary movement until he started taking that medication. It was instantly, I mean, like that afternoon after he took it that morning. And I'm like, what are you doing? He said, I don't know what you're talking about. And I said, your fingers are moving. He said, no, they're not. And I said, yeah, they are. So anyway, he came off of that. And then we started the process of trying to find out why his foot was numb. And so going to different doctors to try to find his, issue why his foot wouldn't wake up from the procedure. We found a doctor and he said, I think you need to see Dr. Sung in Birmingham. And so that's how we came to see you.
Okay. And so you knew you had Huntington's in the family, but that really wasn't on the radar, right? You didn't really think that what you were experiencing was similar to what your family member had experienced with HD, right?
Exactly. I mean, everybody up here told me I was too old at 60 to have it, be in it.
Okay. So then when I brought that up as a possibility, it was a shock, right?
Absolutely.
It was a complete shock, yes it was.
Yeah. And I think that's really important. What you noticed is that other doctors who would evaluate you told you you were too old, right? And there's not a way that it could be HD, right?
That's exactly right.
And other doctors and other maybe friends and family also maybe noticed that and thought there's no way that it could be. Or were you older than your? Remind me who your family member was who also had HD.
My mother was like, she was 45 when she first got it and 55
Okay.
when she died. And
Okay.
my grandmother had it all my life. So she was
Okay.
an old woman when I got to know her.
Okay. So that's an important thing to notice is that your mother, who you inherited HD from, had actually passed from the disease at a younger age than you were presenting to see me for the first time. Is that right?
Exactly.
So since you had already passed that age where she had passed from the disease, you kind of, in the back of your mind, thought, well, maybe I'm home free from this HD thing. Is that right?
Exactly right.
Exactly. Yeah. We thought because of him being 60 years of age or just about to be 60 that we were home free, like you just said. But when we came to see you and then you did the lab work and gave us the results, we realized we weren't home free. We were wrong to even thought, that we were free.
And obviously that can be shocking. And I tried to do my best to be gentle with it and to support you guys as the diagnosis was coming to you, but it's still a shock since you weren't expecting it. So tell me a little bit about your initial reaction to it and how good or bad, how you felt like me and our team here helped to support you through the initial diagnosis.
You did a great job.
Yeah, we were totally shocked, to say the least. Because he had had no symptoms whatsoever prior to that procedure, which I don't know if stress led to these issues or whatever, but we met you and your team of doctors and nurses. It was amazing. How you made us feel at ease and the hope and the care and, just the hope that there's something that's going to be out there to help.
Okay, so emphasizing that even though we don't have a cure for HD now, that there's still hope in the form of treatments for symptoms now, and then also research ongoing for a cure in the future. Those things were really important for you guys as the diagnosis was made, so that you could continue to have hope with it. Is that right?
That's
Absolutely.
exactly right.
Yes.
Exactly right. My mother and my grandmother suffered terribly. And I
Okay.
don't have to suffer like that at home.
How important was the team of, you guys know because you come to our clinic, how important was it having other team members around with other areas of expertise to kind of come and support y'all as the initial diagnosis was made? How important was that in kind of buffering against the shock of this new diagnosis?
It was very important. We got to get different ideas and different opinions from different clinicians. The physical therapist would come in and talk about, different things, the dietitian, the nutritionist, the pharmacist, your nurses, Jenna, Candace. We all had a good relationship and still do to this day. And I don't know what we would do without you guys because you reassure us. And I'll call Candace or I'll call Jenna still from time to time and say, hey, here's a question I have. And they just kind of put me at ease about, what's going on that day. So yes, it was, you guys are really important.
Okay. All right. That's great. And then tell me just a little bit overall about the impact of the diagnosis. Obviously it was a shock, and that had an impact on the two of y'all. But what about for the rest of your family and HD being a genetic diagnosis? What impact do you feel like the diagnosis had on the rest of your family?
Well, Tom and I chose not to have any children because of his fear of the diagnosis of Huntington's.
Mm-hmm.
But he does have a daughter by a previous marriage, and she's 42. 42. And when we told her, she was totally devastated, naturally. She has 2 natural children and 1 adopted son, 2 girls that are naturally hers and 1 adopted son. So they weren't there. We made that clear ahead of time that we just wanted to talk to them.
She didn't know because she didn't know she was at risk because her mother wouldn't let me tell her.
Okay.
She had no idea. She was completely blown away. So you can imagine, how she felt, but she doesn't want to get tested, and she just doesn't talk about it.
Okay. How has that initial shock over time, how has that kind of evolved, both for the 2 of y'all and your daughter and your interactions with your daughter? How has that changed maybe over time?
With her, I think it's the shock has lessened.
Yeah, easier to deal with it. She still won't talk about it at all, but
we try to get her to come to continuing education days that we love to come to, and she doesn't want to. She just doesn't want to acknowledge it, I don't believe. But as far as we go, the initial shock is kind of still there, but on a lighter note. You just pick up yourself and go day by day. There's a different set of circumstances every day.
Out of mind, out of sight, or out of sight, out of mind.
Well, you tackle each day, you take one day at a time and take it the best that you can, right? And I know the 2 of y'all do a great job with that. You hit it head on and you fight it with everything that you have, and you're not going to let it come to you and take it lying down. And related to that, and related to what we were talking about earlier with hope, tell me a little bit about your participation in clinical trials, and how you feel like that has given you hope, and changed your outlook on the disease.
Well, go ahead, Jim.
The clinical trial that we were involved in was actually amazing. We were so excited when we were accepted to be into the program that we couldn't even sleep or eat or do anything but just talk about it to each other, because we were trying to be on that download side of, hush, hush, don't bring it all up because you don't want to give anybody false hope or whatever. So we're just so intense inside about the whole ordeal. And it was just amazing to go through that, and kind of an honor to be able to do that. So we thank you for letting us do that. However, the results were not what we had hoped it would be, so that was a big letdown.
But there's hope for somebody else.
Yeah. And so we're just hopeful that, that trial is going to continue on, and more research and more trials, and hopefully Tom can be a participant again.
Yeah. And with each trial, even if it's not the success that we hope for, we learn from it and we use it to inform the next trials. And that's still ultimately part of the legacy that you leave, is getting to participate in these trials and advancing the science, right?
Yeah.
Exactly.
I talk a lot about how when I first started doing HD trials, we were investigating things like creatine powder, which you can get in GNC. And now we're talking about all these newfangled genetic treatments and therapies, which, we've just come so far. And we owe that success to patients like yourselves who participate in that journey. We couldn't do it without you. What last message would you say, if you wanted to give an overall final message to clinicians who are making the diagnosis of HD in their clinics with their patients? What words of wisdom or words of advice would you give to them?
I think your patient is going to be in disbelief, denial. And I think the best thing that you can do is to be compassionate, stay in touch, phone calls.
Be helpful. Be helpful.
You don't know what it means to have a phone call from you guys, just to say, hey, how you doing? Can we do anything? Has Tom's this changed or that changed or whatever? And you just kind of ease us through the transition and the changes, and it just makes all the difference in the world.
Great. Just the calls to check up on you, right? And to know that you're on our mind. So I think those are great things, just to keep the hope alive and overall bring a message of hope. I think that's really important.
Yes. Definitely.
Yeah. Yes, sir.
All right. Thank you for your time today.
Thank you.
And thank you to our patient and family for sharing their experience, to kind of unpack a little bit more about what they've experienced and described in their lifetime. We'll go through a little bit of the HD triad in greater detail. So the first of the HD triad is going to be your motor manifestations of HD. And the most common symptom by far in HD is chorea. Chorea is defined as brief, semi-purposeful, involuntary movements. So the word chorea actually comes from the Greek word for dance. And the important thing in recognizing chorea is that these movements are non-rhythmic and non-patterned, to differentiate it from tremor, right? Tremor is supposed to be rhythmic and oscillatory, but chorea is kind of this arrhythmic, semi-purposeful, involuntary movement, and it progresses from these small, infrequent focal little twitches and can progress to these large, constant whole body movements. The movements tend to flow from one body part to another, and the important point I wanted to bring up is that even though the chorea of HD is an involuntary movement, if you have involuntary movements in your face and throat area, then obviously can affect voluntary movements such as speech and swallowing. And then involuntary movements in your arms can affect coordination. Involuntary movements of chorea in your legs can affect gait, right? So just this concept that even though chorea is an involuntary movement, can also have impacts on voluntary movements. The other motor manifestations of HD can consist of tics and dystonia, and there's slowing or bradykinesia of smooth pursuit and saccadic eye movements, and then bradykinesia and rigidity in other areas of the body as well. If you think about this and know about other movement disorders, the bradykinesia and rigidity sure does sound an awful lot like Parkinson's disease. And there are some features that are similar, but the abnormal involuntary movement of Parkinson's disease would be a resting tremor, whereas in HD, it is the chorea, as we discussed. So that's an important distinction. And I also find that the slowing of smooth pursuit and saccadic eye movements to be a really key motor manifestation that distinguishes HD from many other disorders, including other causes of chorea, right? Other causes of chorea tend not to have this impairment of smooth pursuit and saccadic eye movements. So those are the kind of key motor features to key in on for Huntington's disease. So to further illustrate the point that I was making about chorea being an involuntary movement but having impact on voluntary movements, I have two patient examples here. Both of these patients have HD. This first example on the left is a patient who actually is a draftsman. And so he's demonstrating his handwriting here. And if you can see, he has chorea in his trunk and in his arms, and it's impacting the clarity of his handwriting, which, you know, choosing to write something down is a voluntary movement, but his involuntary movements, you can see, are impacting his writing. He's writing, "This is a sample of my handwriting." And you can see his handwriting is messy. And this is actually very disturbing to him as a draftsman, because he used to pride himself on having very neat and tidy handwriting. The video example on the right is one of my patients, and I've asked him to kind of walk parallel to the blue line taped on the floor. And you can notice that, especially as he makes turns in walking, and I'm going to play that actually one more time, the chorea that comes out in his legs and in his trunk gives him a little bit of balance difficulty as he turns. It's not terrible, but you can imagine that if it continued, if he walked greater distance and had a lot of change in direction, there would be significant impact there. And then also this point that chorea is present at some point in the disease in 90% of individuals with HD, right? So chorea in HD is so common, it used to be known kind of as Huntington's chorea. We've really tried to change that nomenclature to Huntington's disease because there are many other aspects to the disease than just the chorea, but just to honor the fact that chorea is very common and prevalent, and just wanted to make the point about that. So with that, and hinting at that, the other aspects of the disease that are very important, I'm going to turn it over to my colleague, Mr. Williams, to tell you more about the other non-motor features of HD.
Thank you, Dr. Sung. Yes, we're going to continue on with our Huntington's disease triad in discussing some of the cognitive manifestations of HD that our patients can experience. First is that of the learning and memory problems, really having slower processing times and more implicit with their memory and being able to recall through the progression of the disease. Next is that of executive function, that planning, organizing, and patients can really begin to perseverate in regards to their executive function. And then lastly, it's that of language, difficulty initiating, organizing speech, which overall adds on to some of those motor manifestations that Dr. Sung was helping us to appreciate, with that being mainly of chorea. Now we're seeing some of those cognitive issues and problems that our patients begin to experience. So moving from the aspects of our cognitive manifestations, we still have other elements that patients begin to have. That's lastly of perception. Not only do they have emotional unawareness, but sometimes just even understanding the condition itself as memory, they begin to struggle with their awareness, which begins to create burden for families and community. And as you know, Dr. Sung works in the Center of Excellence. I'm in that long-term care space, and that really begins to impact as patients have to be transitioned sometimes to long-term care facilities, and assisting and having families who aren't able to be with the patient on a continuum. Ensuring that the staff is aware of what these cognitive manifestations of Huntington's disease, really because one of the main areas is that of motor. We also need to ensure that we're educating all of the caregivers of the cognitive manifestations that are there. And we see here that while motor problems and motor symptoms can be so prevalent, actually the cognitive symptoms often precede that of the motor problems. And then really, due to the duration of the disease, majority of our patients will actually experience some element of cognitive manifestation during their lifetime. So now moving from the motor manifestations of the triad, cognitive manifestations of the triad, we're going to end off in the area that I live mainly, and that's of the behavioral manifestations. And really, I want you to understand that depression and suicide is estimated to be that of 5 times higher than in the general population. And depression is so frequently observed with an estimated prevalence of approximately 50% of our patients with Huntington's disease. Not only is depression and suicidality something that we're concerned about, but the impulsivity is also common. And that impulsive behavior that patients will have can also assist in our increased risk of suicide. Patients can have obsessiveness and perseveration, and that's about 40 to 80%, I'm sorry. Next is of irritability, that's of some 70%. Just general apathy that our patients can have, and that's 60 to 70%. And then the prevalence of psychosis, that's more variable, but the onset of psychosis in Huntington's disease is generally appreciated and seen in later phases of the condition. And then lastly, I mentioned that 5 times higher risk of depression and having suicidality. Really, we want to understand specifically in regards to the suicide risk that patients with Huntington's disease, generally has a higher rate of suicide than patients with other neurodegenerative disorders and in the general population. And really that increased rate of suicide ideation were found immediately before receiving their Huntington's disease diagnosis. And when independence becomes diminished. So I'm often sharing with caregivers and staff members that we want to ensure the patient is feeling that community and family is around. We want to assess any specific behaviors of suicide risk, isolation, withdrawing that patients can generally have, because really the impact of their suicide ideation on patients with Huntington's disease is associated with depression and anxiety and aggression that patients can have. And then really, when we see the most severe ideation is linked with current or historical history of alcohol abuse. I'm going to hand it back over now to Dr. Sung as we continue going over the stages of HD.
All right, thank you, Mr. Williams, for discussing the non-motor features of HD. Really critical to understand those. As we think about all of the symptoms in HD and how they affect staging and how they develop over time, gives you kind of a sense of what the journey of a patient of HD entails. So our staging in HD is primarily based on the functional ability at each stage. If you have both motor, cognitive, and behavioral symptoms, obviously they can have a lot of impact on your overall function. The main areas that we look at are occupation, finances, domestic chores, activities of daily living, and the care level that's required for that patient. And this is a 0 to 13 point scale, with kind of your 11 to 13 being stage 1, and then stage 5, which is kind of end stage disease, HD, is a 0. They are not able to do any of these things for themselves. We can break this down into kind of early, middle, and late, or if you break it down further into 5 stages where you break down each area into a few more. You have early intermediate, late intermediate, early advanced, and then advanced. And if you look at these stages, they really segregate based on ability to do key aspects. So in the early stages, it's really about ability to work or not. And then in the intermediate stages, it's really about their household chores. Are they able to maintain those things? And then in the advanced stages, it really hinges on their ability to do their ADLs for themselves, and what is their care environment, and when do they transition to a long-term care facility. As far as how this progression goes over time, obviously it varies from person to person, and can vary significantly based on their CAG repeat length as well. But on average, what we quote to our patients is that the natural clinical course is about 15 to 30 years from symptom onset to death in an adult patient. But that also can mean if you are 65 years old when you first start having HD symptoms, that your lifespan can be a normal length, right? But also then if you are, say, on the younger end, 30, 35, then you will definitely have a shorter lifespan, and also be reaching the time that you will need long-term care facility placement at a much younger age than your typical long-term care facility patient, right? So that's one of the challenges of this disease. Just as in all other neurodegenerative disorders, the cause of death is not the disease itself, but complications such as pneumonia. And we know this to be true with our other diseases like Parkinson's and Alzheimer's, right? I mean, they primarily die due to complications such as pneumonia. The other point I wanted to make here when we're talking about death and the progression of HD is to reemphasize the point that Mr. Williams made about the difference between so we talked about death because of pneumonia, heart failure, other things, very common in HD, but also common in Alzheimer's and Parkinson's. But one of the big distinguishing things is the second most common cause of death in HD after these infectious type complications is suicide. And suicide doesn't even crack the top 10 causes of death in our other neurodegenerative diseases. So important feature to notice there. And then as far as how this natural history evolves over time, I really like these graphs that were developed by my colleague, Chris Ross. And what it really shows is, if you look at the graph on the left, that the symptoms are already accumulating prior to the diagnosis, which is that middle black line. The symptoms are already accumulating, and then over time, as they progress, their function goes down as their impairment goes up, and that just kind of goes together. And then what about other biomarker changes? On the right graph, then you see the diagnosis being made right there in the middle with the black line, but many of these other changes that we can see both on imaging, biomarkers, things like that, can be detected if we have sensitive enough imaging measures, maybe even before the heart of the disease symptoms actually start. So just to say, this is a genetic autosomal mutation that is present their entire life. So it just makes sense that there are changes happening even before changes happening in the brain even before they start to manifest symptoms. So going back to the genetic testing for HD, how do we do it, right? I think genetic testing in HD, you really have two main groups. You have your confirmatory testing and your predictive testing. Confirmatory testing is when a patient comes and they clearly have symptoms, these symptoms that we just spent all this time describing in the HD triad. They've got all your classic symptoms, and you're ordering the genetic testing to confirm what you suspect, right? That's confirmatory testing. And then predictive testing is the opposite, right? So they know they have it in their family, but they don't have any of the symptoms that we just discussed in the triad. So they're completely asymptomatic, and they're trying to electively go through testing to predict what's going to happen in their life, to give them the knowledge to be able to plan for their life. So the recommendations for how we approach those things is very different. But all that to say, if you sum those together, despite the wide availability of predictive testing, the average cash cost of HD genetic testing in the United States is about $300 to $400 now. So it's not a high expense. So despite that, only 10% of individuals in the United States who are at risk for developing HD opt to take the test. And why, right? And the reasons why are myriad and complicated, largely due to this concept of they feel like there's nothing that can be done for it, and so they don't want to be tested. We will talk in future talks about how to manage this disease. I would argue that that's not exactly true. I think there are things that we can do about it. Yes, we can't cure it. Yes, we don't have disease-modifying therapies yet. But there are ways that we can manage the disease, and maybe being proactive and getting testing can help us to do things for it. So as we're thinking about the genetic testing itself, we've talked a little bit about the gene and the mutation already. And we talked about that 40 repeats and higher is your fully penetrant symptomatic mutation. But the number is never zero. And this is the point that I make. Even on the normal copy, there are always some number of CAG repeats, right? So the normal copy is going to be something like 18, 20, something like that. And a person with HD is going to have one copy that's greater than 40 and one copy that's like, 20 or something like that, right? There are rare intermediate range mutations, so 26 to 35, or the reduced penetrance 36 to 39, but those are much more rare. What we generally feel is that if it's kind of mostly all or none. So either both copies are less than 26 and they don't have it, or one of the copies is greater than 40 and they do have it, or they will develop the symptoms of HD. For the rare patients that have a reduced penetrance range, so I just had a patient yesterday, had 37 CAG repeats, had some mild symptoms, primarily non-motor symptoms of the disease. And we're just going to chalk it up to maybe it's a mild reduced penetrance version, but still call it HD. How do we do the genetic testing? There are genetic testing guidelines that are recommended by the HDSA. The guidelines are in the process of being updated to accommodate for telemedicine options and things like that. But the original guidelines recommend a few main things, which is they recommend genetic counseling prior to testing. And this is really for predictive testing. Psychosocial assessment, and that's really assessing their readiness to receive the results of testing. In-person results disclosure with a support person present, and supportive follow-up after the results disclosure. So this is the protocol for predictive testing. They did say that the protocol can be abbreviated for confirmatory testing. You don't need to do quite so much, but for predictive testing for a person who doesn't have symptoms, and because of the significant impact that can be, all these steps are recommended. If there is a positive test result, the key thing is that does not equal the start of the HD diagnosis itself. So say you're 20 years old and you go through predictive testing and you test positive. We don't say that at that point that they have Huntington's disease. That means we say that they're a mutation carrier, and at some point they will develop the disease down the road. That is an important distinction for insurance purposes and things like that. But if you understand what that does to a person, then they often will feel like they're a ticking time bomb, right? So they have this knowledge now that they carry the mutation, and it may be 10, 15 years before they develop any of the HD triad symptoms, but they are constantly waiting for that other shoe to drop. And that's a tough place to be in, and it's a significant source of stress and anxiety. But then you also have to balance that against the stress and anxiety of not knowing your gene status, right? And so that's the conundrum that these patients face, whether to test or not to test. Obviously, if it could be many years before they start showing symptoms and they just carry the mutation, you can think about that there is potential for discrimination based on their gene status, either at work, by their health insurance. Life insurance, disability insurance can either reject or charge higher premiums, things like that. So these are very complicated ethical considerations to undergo in HD. And there are also other ethical considerations as far as testing of children, balancing the right to know versus the right not to know. So these are complicated areas. You know, I've certainly had patients come to me and say, like, okay, I have it. Can I go ahead and test my 8-year-old who then is at risk? And we generally don't recommend the testing of children when they're not symptomatic, just at the order of parents, because it takes away the autonomy of that child, right? And it takes away their ability to decide later in life, did they want to know or not, right? But if the parent has decided for them, that's a little bit unfair. So we generally don't recommend that. And then there's also this other concept: what if a parent has chosen not to test, and then their child tests and tests positive? Then that can out the adult parent, because that means that the adult parent who chose not to test, they must carry the mutation if their child has it, right? Because this genetic mutation, that's how autosomal dominant mutations go. They don't skip generations, right? So there's just a lot of complicated ethical things that we can get into when we get into genetic testing. All those ethical things, plus the cognitive and psychiatric symptoms of the disease, plus the motor, how they affect the wage earning years, as we've talked about. There's a significant emotional burden of HD. You have your immediate family member who typically cares for the patient, and it could be the spouse. The non-HD spouse can experience this kind of continuous consuming trauma. But also, what if the caregiver, say, is the son of the person with HD, but that son maybe is at risk for developing it themselves? So then they nurse their parent, maybe nurse another sibling, and then ultimately succumb to the disease themselves while worrying about passing it on to another generation, right? So this family generational emotional burden of HD is great, and can be very complicated. Because of that, there's great importance in care planning, involving the whole family in the care planning and decision making, and involving more than just one clinician on their own, the importance of a multidisciplinary care team. Mr. Williams is here representing psychiatry, and I'm here kind of representing neurology. And that's very intentional in how we're doing these talks, is we want to emphasize the importance of a multidisciplinary approach to approach this very complex and difficult disease, but also to have multiple people to support the patient and entire family. We do this together as a team. We do this together as a family. So that brings us back to our key learning points for this talk, that HD is a genetic neurodegenerative disorder characterized by symptoms across a triad of motor, cognitive, and behavioral symptoms. The genetic aspect of the disease means that it has impacts on multiple generations of an entire family. And the HD gene can predict to some degree the age of onset, rate of progression, but genetic testing should be undergone with special considerations, right? All these ethical considerations that we talked about. And then this broad impact of HD on the family is best met with a multidisciplinary care team approach. And with that, we'll take any questions that you might have. Thank you for your attention this morning.
Hello, and thank you for joining us for our live Q&A. Dr. Sun, I'm going to go ahead and start with our first question for today. Could a low-carb ketogenic diet help with improving the symptoms of HD and slow the progression?
I think that's an interesting question. We've really been looking at all sorts of ketogenic diets or low-carb diets for treatments of other neurologic diseases, such as epilepsy, things like that. The premise of using low-carb ketogenic diets in neurologic diseases is to force the brain to use alternative fuel sources when it's not using the primary fuel source of glucose efficiently, to see if it can kind of drive better function, better neuronal function. We've not studied this specifically in HD as far as I know, but I think it's tough in an area like HD where there's considered to be a lot of already stress on the neurons. And especially if the Huntington gene is normally implicated in DNA repair, and if you put stress by forcing through other metabolic pathways, does that induce more mutations that an already stressed system cannot repair as effectively? I'm not sure how it would respond. We have tried multiple supplements that are operating along the basis of antioxidants and things like that. So we've tried high-dose coenzyme Q10, we've tried high-dose creatine, and in those clinical trials, those did not statistically significantly improve Huntington's disease. But admittedly, those trials were all done in an era where we could not measure HD as well. We didn't have the imaging biomarkers that we have now. We didn't have really high resolution assays of quantitative mutant Huntington protein to measure, even if there's not clinical changes, are there other changes that those supplements are improving? So it's interesting. I think retrying some of these metabolic things would be interesting in an era where we can measure the disease and have better biomarkers for the disease. Like NFL wasn't even a thing back then when we did these things. So it would be interesting to try, but probably those will remain on the back burner while all these genetically interfering or modifying therapies are really at the forefront now. But I can see us returning to that later down the road. But right now, all the energy is focused on disease modification through genetics.
Okay, all right. Next question is there a similarity between Huntington's disease and Parkinson's disease in to control the development, in terms of symptoms? And then is it possible to control the development of Huntington's disease? And what are the possible therapeutic methods to reduce those aggravating symptoms?
Yeah, I think so. Our next 2 hours, we're going to focus on the management of the non-motor and then the management of the motor symptoms. So we'll talk more about that. But you pick up on something very subtle here, which is outside of the chorea of Huntington's disease, there are other features of motor features of Huntington's disease that are actually very similar to Parkinson's. So dystonia, bradykinesia, which is slowness of movement, those features are very similar. But these kind of hallmark features, like a Parkinsonian resting tremor, Huntington's patients will never have, and then Parkinsonian patients will only get chorea when they're taking very high doses of levodopa for their Parkinson's disease. So, but we use our knowledge of the dopamine underpinnings of the motor features to guide how we treat and manage the symptoms. I would argue that we have very effective treatments for both the motor and the non-motor features of the disease. You know, one of the things that I say all the time is that, take depression, which is a common symptom of Huntington's disease, as an example. The depression of Huntington's disease is often more responsive to pharmacologic treatments because there is a biochemical basis to it based on the genetic mutation that causes changes in neurotransmitter levels. And so therefore, they're often more responsive to medications than maybe, say, your average patient with major depressive disorder across the country. So, but yes, we generally have very effective pharmacologic treatments and non-pharmacologic treatments as well. But I think we can very nicely manage the symptoms of the disease. And then we look for disease-modifying therapies in the future to hold the control that we can get of the symptoms with the treatments that we have now for longer periods of time.
Actually, talking about depression, our next question is, which I'll jump in on this one as well, is why do Huntington's disease patients have increased suicide rates in comparison to the other neurodegenerative disorders? So wanted to go and answer this question along with Dr. Sung, that we know with Huntington's disease in comparison to the other disorders, neurodegenerative disorders, that impulsivity with Huntington's disease is a major concern. And then as patients begin to have loss of function, which we'll talk about in our next two presentations, as those patients begin to lose those functions, they begin to isolate more. So when you add their depressed state, impulsivity, and their isolation, kind of leads to that triad of storm, which then begins to increase that suicidal rate in our patients with Huntington's disease. Dr. Sung, any other thoughts?
Yeah, I think that's great. I think it's the combination of depression and impulsivity that really drives the suicide risk up higher in Huntington's disease.
All right, our next question is, how common is Huntington's disease to have a late onset in the 60s, 70 age range?
I think it's much more common than people think. I think if you have someone in their 60s and 70s and they present with chorea, to me, it's going to be Huntington's disease until proven otherwise. I've seen, maybe a dozen new patients in the past year with new onset Huntington's disease with no family history, with symptoms starting in their 60s or 70s. And if you think about it, like that is the population of people that would not have a family history, right? Because they have a very mild mutation that's been passed along from generation to generation, but whoever they inherited it from maybe died of natural causes before they could start showing symptoms of Huntington's disease. So they didn't know they had the mutation in their family. But you use that these later onset presentations of Huntington's disease will have a primarily motor presentation as your clue. So if they present with the motor symptoms, the classic chorea in your 60s and 70s, you should think about that.
Yeah, Yes.
And that kind of leads into the next question, which is screening tools. What should be the first red flag? Is it motor symptoms alone? I think if it's an older patient, then yes, you should look for those as a screening thing. The other things are, if you don't look at, there's a lot of argument. We know that the non-motor symptoms, the depression, the cognitive things can present before the motor symptoms for sure. But if you don't have a family history, we can't just screen every single person that presents with depression or cognitive symptoms in their 30s and 40s for Huntington's disease. That's not going to be like your top of your list, top of your differential. But if you have some of the depressive features, the perseveration is a common early feature, which is, this what I call broken record thinking, that tendency to ask the same questions over and over again. Depression, perseveration, and then some cognitive kinds of things. If you have those and you have a family history, then even in the absence of motor symptoms, I think you can use that as a screening or something to think about as possibly being HD.
We have a question. How do we approach topics like driving with patients who have Huntington's disease? I know we're going to talk a little bit more about this in our upcoming presentation, but didn't know if you wanted to kind of talk about some approach and how do you tactfully approach that?
Yeah, driving is a tough one. I think Kevin, you deal with a lot of patients with Alzheimer's disease as well. Whether this whole concept of driving and loss of independence, that's where the rub tends to be, right? We want our patients to maintain their sense of self and their sense of independence as much as possible, but driving is something that's a public safety issue, right? And so if that is a significant problem, then we're obligated as medical providers also to protect the general public. How I generally approach it is a couple key things. One is when it comes to the discussion about driving, I would rather be the bad guy, and I don't want the family member to be the bad guy. I will take that on. I will be, the person, if I'm recommending withdrawing or not driving, then I'll be, I want the patient to look at me and blame me, not their caregiver. I do rely very heavily on the caregiver telling me that it is a problem, and then we can address it. But I'd rather address it earlier than later. The other things too are that if we address it early, and there's a significant motor component to it, like the chorea and stuff is causing them difficulty with managing the steering wheel or the pedal. Sometimes, and in small instances, I've had it where when we treated the chorea, the driving got better and everybody felt okay with that person returning to driving. So it's not outside of the realm of possibility that can happen. But I prefer to do that, and then discussions on getting the patient to voluntarily relinquish driving if they can. I use kind of letters to the DMV to get their license revoked as a very last resort. The other things are most states have formal driving assessment clinics and availability to do driving assessment. And I think using that. So sometimes patients will say like, I think I'm fine to drive. Okay, well then great. Let's do the driving assessment clinic and see what they say. And it's this third party assessment that's more formalized and can give us assessment about their driving.
Well, we have come to our time, so we're going to wrap up and we'll go to our part 2.
We'll take a break first and then we'll come back for part 2.